And just for anyone, if you've got any questions throughout the day, please feel free to either use the Q&A tab or the chat function. And if we don't address them at this moment in time, we will try and address them later on. Sarah, I see you have your hand up.
Yes, hi, sorry I'm late, but I have this question. My Optune started to do a buzzing sound recently, not always, sometimes, and the Novocure told me they would send me a new device.
Laura, we will take that offline. That's not a question for the day.
Okay.
Thank you, sorry. I know, I need to get...
Okay. Can I use it?
Yeah, I'm free.
Yep. And then I'll just click on. Yeah. Cool. That's right. Let me have a. Am I allowing that?
No.
No. Okay. Good. Right. Can you hear me remotely?
Yes, we can.
Yes.
Yes.
Yes. Can someone just confirm if they can hear me remotely?
Yes. Thank you.
Yes, I can, Dr. Williams.
If not, just give us a second. That's
No, it's fine. I need to share. Please,
Yeah.
Okay.
Okay.
But no, just bear with me. Now, can you hear us?
Can you hear us remotely?
Yeah.
Yes, thanks.
Yes, I can hear you. Yep.
Thank you very much. No. Go on then.
That's just close my pathway.
Okay. Right.
Sorry about that.
Okay. So hopefully everyone can hear and see me, and we'll keep an eye on the chat. So if you've got questions, I'm happy to. I'll try and if you've got questions about individual trials, I'll try and take them as we go along. Otherwise, I'll try and talk about stuff at the end. So I've got about 25 minutes where I'm going to try and talk about the clinical evidence and trials and talk a little bit about updates. So just very briefly, because of the way that we've sequenced the day, for those of you not familiar with Optune, it produces a tumour treating fields and patients wear adhesive patches that hold insulated ceramic discs. Normally you use 4 of those arrays. They're attached to the head and the patient has to keep their head shaved. And then those are connected to a device that produces the alternating electrical field. And we're aiming for people to wear them. It says here at least 18 hours a day. We aim for people to wear them for longer than that. And I'm going to explain why in a minute. And then those arrays are connected to a device. The device consists of the part of the device that actually makes the alternating electric field along with a removable battery, and patients are provided with a charger and multiple batteries so they can change them throughout the day, along with a bag to carry the device. And we'll talk a bit later about some of the more practical aspects of Optune. Okay, so just very briefly, there's a big problem in medicine about how we work out whether things actually work. So the simple fact is that for minor illnesses, if you leave them, most stuff will get better by itself. And for bad illnesses, lots of bad things happen to people irrespective of what you do. So in both cases, it can be very difficult to work out whether what you do actually makes any difference. And that's really the basis for running randomized trials. And the point about a randomized trial is we randomly assign patients to treatment. And so therefore the difference in outcome should only be due to the difference in treatment and not due to patients being older or younger, for example. That's at least the theory behind randomized trials, and it's why we're so keen on them. Okay, so there are two major randomized trials of Optune in GBM. They're called EF14 and EF11. There is also a systematic review, which I'll touch on briefly. But in terms of randomized trials, really the important one is EF14. So EF14 was a big international multi-center randomized phase 3 trial. Everyone in it had what we would often call the Stupp regime, which is chemoradiotherapy followed by chemotherapy with temozolomide. And once you'd finished your chemotherapy, you were then randomly assigned to either having temozolomide alone, as you would standardly do, or have temozolomide and Optune. And they weighted that randomization 2-to-1. And the reason they did that is when you do that, you actually reduce the statistical power of the trial. So you have to recruit a few more patients. But the main reason is it makes it much more attractive to patients. Because if you imagine being a patient, if you go into that trial, you have a 2 out of 3 chance of getting the novel therapy, which is why they designed it like that. And you started TTF about the same time you started your temozolomide after the chemoradiotherapy. And at progressive disease, you could have whatever therapy your clinician thought was appropriate, but you should continue the temozolomide on to second progression. And that's actually quite an important thing. Some of you might know that in glioblastoma, there's this big problem with pseudo progression versus progression. Pseudo progression means it looks worse and then gets better. Progression means it looks worse and is truly worse. And they are notoriously difficult to distinguish. So one of the things I like about this trial is instead of trying to distinguish, they just said carry on to second progression, because that way, if you actually thought the patient had progression, but it turned out to be pseudo progression, it didn't matter. You just kept going, which means you don't stop Optune unduly early, which is important. And as well as survival, patients had an MRI every 2 months. And importantly, the people who looked at the MRIs were blinded, as in they didn't know whether patients were on Optune or not. And I'll talk about why that's important in a minute. So this is the flow chart, which I've really just put up to remind myself of the numbers. So there were 695 patients randomized, 466 to TTF and 229 to the other arm. And you can see you don't quite get everyone who goes all the way through. So you've got about 40 patients withdrawn in this arm, 14 withdrawn in the other. That's not unusual for clinical trials. Okay, this is pretty standard in terms of clinical trial run through. Okay, patient characteristics are fairly balanced against the two. So the 2 columns here are the experimental arm and the standard arm. And you can see that median age is about the same. Sex is balanced. Ethnicity is pretty balanced. Importantly, things that we know that predict survival, mini mental state exam, extent of resection, MGMT promoter, all of those are pretty balanced as well. So it looks like the randomization works in that it's given us 2 balanced cohorts who should do equally well. There's no good reason to think that they'll have different survival. But they did have different survival. Left-hand side is progression-free survival. Right-hand side is overall survival. Overall survival is much more important, and I'm not really going to talk about PFS. And the important thing is that overall survival went up from 16 months in the temozolomide alone group. Median overall survival went up from 16 months to 20.9 months, which is technically 4.9 months, but most of us think of it as being 5 months. Okay. And one of the nice things, so this thing on the right hand side is what we call a forest plot. So hazard ratios are the measure of relative benefit, where 1.0 is no benefit because the hazard is the same in both groups. On the left favors TTF, on the right favors temozolomide. Each of these groups is broken down. The point is that in all of the subgroups, the hazard ratio is pretty much the same. So from a clinical trial perspective, Optune offers the same relative benefit in older patients, younger patients, patients who'd had surgery versus patients who had a biopsy, MGMT methylated versus unmethylated. I will just say that hazard ratio is a measure of relative benefit. Because absolute survival is worse in patients with MGMT unmethylated tumours than MGMT methylated, the absolute improvement in survival in terms of numbers of months may be smaller in the worst prognosis groups. And that is kind of just the way that the maths plays out, I'm afraid. In terms of side effects, you'll notice that both groups are getting some side effects. So both groups get some blood disorders, some injury, poisoning and procedural complications, but they're pretty much the same in both groups because TTF doesn't influence that. What it does influence, is, which isn't on here, is skin side effects. So the big difference in the use of Optune is skin side effects. So 50% of patients using Optune get some degree of significant skin side effects, but only 2% get very severe skin side effects, which is worth bearing in mind. Okay, so there are some criticisms of EF14. First of all, it's a single trial, and single trials can mislead you. Maybe that trial was positive for one reason, but other trials would be negative. It's not blinded. So blinding is important. If you know what treatment patients are getting, and if patients know what treatment they're getting, they are more likely to do well. And there's a well-recognized placebo effect. But that is much more powerful for patient-reported outcomes. So particularly if you ask quality of life and you give patients a placebo, their quality of life improves. It has much less impact on overall survival, because unfortunately, just being given a placebo with a disease like GBM does not necessarily make you live longer. Okay, and it is important that we talk about overall survival, and that's why I focus on overall survival. And of course, there's the skin toxicity, which is a real issue, and we need to deal with, and we need to manage. The other thing I will say, just as to bear in mind, Optune is an effective treatment for GBM in that it improves survival. The improvement in median survival we saw in EF14 was more than the improvement in median survival that we saw in the original Stupp trial when we added temozolomide to radiotherapy. So it is of a comparable impact, but it's still not curing lots of people. Okay, so it's definitely an improvement, right? And the impact of TTF is still less than the impact of other prognostic factors. So we just need to be realistic about how effective TTF is. There is now a systematic review, so this pools results from multiple studies. Again, there's another forest plot. So although this study exists, I will point out, and you can see the numbers here. The numbers of patients in most of these studies are very small. This one, Chen et al. 2022, has got a reasonable number in. But in reality, although there is a systematic review, this is dominated by the EF14 trial. So it's a bit of use because it shows that the other trials don't massively go the other way, but it doesn't really change what we thought. I'm going to talk about EF11 very briefly. So that was a trial in relapsed GBM where patients had previous lines of therapy and then they were randomized between physician choice of chemo or Optune, 237 patients, primary endpoint survival. Importantly, 80% of patients were at their second recurrence. That's the flow chart, which isn't that exciting. That's the breakdown, which isn't that exciting. This is what's actually important. So on the left-hand side is overall survival, and there's no difference in overall survival. So Optune versus physician choice of care doesn't make a big difference in patients with heavily relapsed GBM. So 80% of these are on third-line treatment. What one could draw from this is that nothing really works for third-line treatment. That would be a reasonable conclusion to draw. So I'm not convinced. It doesn't show that TTF doesn't work. It just shows it doesn't work any better than chemo, but the chemo doesn't work very well either. So one of the things I would take away from this is there is clearly a survival benefit for Optune when used at diagnosis. There is not a survival benefit against chemotherapy when used very late on. You know, where that changes, I think is up for debate. Okay. And then just to point out, this was Optune versus chemo. In reality, you can combine them, and probably a more interesting trial of Optune in relapse disease would be chemo versus chemo plus Optune in relapse disease. Okay. So Optune works for GBM in that it improves overall survival, but it works much better up front than for multiply relapsed disease. To be fair, that's true of everything in GBM. If you look at all of the trials, people with relapsed GBM, nothing works very well. The other issue is that wear time matters. And so maybe our focus should be on actually getting the device onto people and helping them use it lots. So there is a bit of data around that. And it's probably worth asking what we can learn from real world data. And I think it's a good example where there are clear licensed indications for Optune. And much of my job is knowing when you're allowed to break the rules and getting my colleagues to agree I'm allowed to break the rules. So just to give you a really concrete example, if you look at the Optune information, it says that you can't use it in patients with missing bone flaps. That's not true. You can do, and it works fine. You just have to be really meticulous about skin care. Okay, so I understand why Optune have that in their licensed indications. So the question is kind of what can we learn from real world experience and actually using it? Oh, actually, and we'll pause before we go on to that. Just pause. Any questions about the trial data? Okay, I'm going to carry on then. Okay, so a couple of bits of real world evidence, which I'm going to go over fairly briefly. The first thing is the post-marketing surveillance data. So this was over 25,000 patients with CNS tumours treated with TTF over quite a long period of time. And so the reason I just want to stress this is if you go back to EF14, you had just under 700 patients. That means if you've got rare side effects, by definition, you won't see them because they'll only occur in small numbers of patients. The advantage of the post-marketing surveillance, you've got 25,000 people. So even if there are rare things, you should begin to see them. And actually, you don't. So it confirms that people get skin side effects, which is, I think, what everyone knows, but you're not getting lots of other side effects. So about half of all people get some degree of skin reaction, 10 to 15 get a funny electric sensation and a heat sensation. And pretty much everything else is kind of unrelated to Optune. The second piece of data comes from the XCures study. So this pooled data from multiple electronic medical records in the US and collected data on Optune. And the nice thing about this is, again, it's relatively large. It's about 1,200 patients. And it shows that there's an impact of wear time on survival. Now, this might be confounded, and I'll talk about that in a minute, but nonetheless, XCures suggests that better wear time has a bigger impact on survival. And then the next piece of evidence for that is a paper by Toms et al., which was a retrospective analysis of the EF14 data. So they went back to the EF14 data, and then they looked at the wear time and they said, well, how much did your survival improve by based on how much you wore it for? So what we've got is we've got another forest plot here. Going off to the left favours Optune over temozolomide. And you can see that if you're not wearing it very much, then statistically it doesn't have much impact. And the more you wear it, the better the impact is. And one of the things I like about this is, I mean, I feel this is reasonable evidence of a dose response effect. Okay, the more you use it, the smaller the hazard ratio gets, the better your survival. advantage. I will just say that all of the wear time stuff may be confounded. We know that patients with GBM who are fitter on average will live longer. And I'll point out that you will only manage very high wear times if you're pretty fit and active. So there may be some degree of confounding. Actually, what's more interesting is this group in the middle. So the group who go from about 60% up to about 85%, my experience is that that group of patients is relatively the same fitness, but it's about working with patients to help them use it a bit better. And there, I still think there's an impact on survival. And then the final study is the Tiger study, where the abstract is out, but the full paper isn't out. And that was from 81 centres in Germany. And one of the interesting things about this is TTF at this point was routinely available in Germany. They enrolled 710 patients. Actually, only 60% of patients started TTF, which is an interesting figure and is one that we might want to discuss. But I would agree that there is a definite group of patients who do not want to use TTF, and it's fine. Whether that figure is 50, 60, 70%, yeah, where that number lies, I suspect will change over time. But there's definitely a group of patients who don't want to use TTF. Quality of life didn't change very much over time. But this goes back to the question that Ola was asked. So when I talked about the EF14 data, I really just talked about median survival because it's a nice, easy number to remember. But in EF14, there was also an impact on longer term survival, and that was replicated in Tiger. And so just for comparison, with Stupp alone, your 24-month survival, your 2-year survival, should be about 26 to 27%. Okay, so TTF really does add to 2-year survival, and indeed it's still adding to survival in Tiger at up to 48 months, just because that's when they stopped follow-up. So from a clinical perspective, there is evidence of an improvement in longer term survival. Whether that means you have to wear Optune for 4 years is not clear at all, actually. So if you wear Optune for a period of time and then stop wearing it, what happens after that remains an unknown. And, you know, there's lots of stuff we could talk about. Okay. And then the final thing I wanted to talk about is one of the values of real world data is about combining interventions. So about the same time as the EF14 trial was recruiting and being run, there was another trial in Germany for patients with only with MGMT methylated GBM, combining temozolomide and lomustine and comparing it to temozolomide. And that showed a benefit as well. But by definition, you couldn't be in both trials at the same time. So you could have been in EF14 or you could have been in NO09, but you could not be in both. There is therefore, by definition, no trial data that tells you what happens when you combine them. So the only data that currently exists is a relatively small paper from Germany that came out a couple of years ago. So they've got 70 patients, all with MGMT methylated GBM, who were treated with combined temozolomide lomustine, of which 29 also had Optune because that's just the way that patients were treated. And you can see that overall survival in those who had chemo alone was 26 months. And when you added Optune, it went up a lot, to the extent that in the period of this study, they hadn't reached median overall survival. So there is some early data that suggests you can combine better chemotherapy and Optune in patients with MGMT methylated GBM, and you seem to get benefits. And I will say that we've done this clinically, and we will be presenting our data at BNOS next year. But you know, our data is even smaller than this because access to Optune in the UK is even smaller. Okay, so the side effects of Optune are pretty much what we saw in EF14 in a much larger study, 25,000 patients. The outcomes in the Tiger study are pretty similar to those that we saw in EF14. And that's important because trial patients are often heavily selected. So knowing that we get broadly similar outcomes in routine practice with Optune as we did in the trial is important. And I think there is reasonable evidence to support a wear time effect. And I think I'm done. Questions? I can stop sharing my screen. Yes. Oh. Yeah. So any questions from the room? Chris?
I think I got most of that. I'm not sure, but thank you. We talked about X cures, and you showed consequence of wearing longer. Going back to your 4.9 months, is there a comparison from that study as medium for 90% users?
So from X cures, I can't remember. From the figure. Oh, sorry. So the question is a good one, which is, does the X cures data tell us about the impact of 90% wear time compared to less? So X cures didn't quite break it down like that. It broke it into high, intermediate and low. And I can't remember it. I think their cutoffs for high, I think, were more than 80%. The figure I remember is from the TOMS paper, which is the retrospective analysis of EF14. So the improvement in median survival in the whole cohort is 4.9 months. In those where the wear time is more than 90%, then the improvement in median survival was 12 months in the retrospective analysis of EF14. Now, I'm not going to get hung up on whether it's actually 12 or 10 or 11. I think the point is there are now multiple studies suggesting that increased wear time improves survival in a relatively dose-related effect. Right. Any questions remotely? I can't see the screen, so if there are, you will have to just unmute and shout out.
I'm just wondering, is there any plans to run it with something like the Aristocrat trial with the what's it called?
Yeah, with
the Sativex.
Yeah. So at the moment, no, because Aristocrat is run as a separate trial, and one of the rules of trials is you can't enroll in 2 interventional trials at the same time, because then you can't work out what's improving survival. Whether there would be interest in doing a follow-up to Aristocrat, including Optune, and I think there is room for a trial of Optune in first relapse GBM. I think that there's definitely value there, and what you would put with the Optune, I think, is kind of up for debate. But at the moment, if you were on Optune, you couldn't go into Aristocrat.
Thank you.
Sorry. Okay.
Hi, Matt, can you hear me?
Yeah, I can.
Hi. Thanks for that. Good. I mean, a good point about hazard ratios and subgroups and absolute benefit. So I guess the follow-on question from that was, is there good data from either EF14 or or post-surveillance about quality of life and sort of robust data on that when you're thinking about perhaps the unmethylated cohort where the absolute benefit might be diminishing?
Yeah, I mean, there's quality of life data from EF14, which shows that the use of Optune doesn't give a significantly different quality of life from not using Optune. Post-marketing surveillance didn't do quality of life. Tiger did do quality of life, but of course it's not randomized because everyone was on TTF. I think my simpler answer is that in general, as long as you pick patients who are willing to do it, the thing that makes patients unwell is progressive disease. And therefore, delaying the onset of progressive disease probably has a reasonable impact on on quality of life. Herben.
Yeah, thank you for a great presentation. Just to comment on your last point, in the Taphorn paper, who reviewed the quality of life, they exactly showed what you just mentioned, that the quality of life in patients with a later progression was better. So they showed the statistical significance about a better quality of life in patients in the treated arm because of the delayed progression.
Yeah.
My question is about the wear time. I'm a bit more skeptical than you, I think. But do you know, with so much data, why there's not a correction done for the performance status? You could look in subgroup analysis of high performance and low performance, and then look in at the wear time.
You could do. I suppose I've got two answers. In fact, if you start breaking it down by performance status, I suspect you don't have as much data as you think. I think the other problem, and this is a persistent problem in neuro-oncology, is that our assessment of performance status, particularly if you're using ECOG, is just a bit lumpy. So it's very difficult to be ECOG 0 because you pretty much have to be at work, which is a challenge. Most of the trials will at most accept people who are performance status 2. So many of our patients end up in this group will end up being PS1, PS kind of 1.5. And not really sure that we tease apart that granularity by using ECOG performance status. As you probably know, the thing I will say next is what we should probably do is use some wearables to try and measure how active people are in a much more granular fashion. But I accept that it's up to me to provide the evidence to actually support that statement, which obviously we can't do at the moment.
Yeah, no, that would be very, very good if we can start doing that. Fully agree.
Yeah, we're working on it. Brainware 2 is coming early next year. Okay. Yeah. Okay, so we are going to have a session this afternoon led by Kathy Oliver on where we're up to with NICE approval. So I don't want to steal her thunder. The subject of NICE approval with Optune is a thorny and very annoying issue, but I will leave Kathy to talk about that. Kathy, I've seen Kathy's slides. She's going to give a really good talk, partly because she was involved in the NICE approval of temozolomide back in 2006, 2007, and she draws some really interesting comparisons between the two. Okay, all right, one more question. Sarah?
Hi, it's Henry with Sarah's husband. Question for you, more on the practical side. I was wondering if there's any plans for miniaturization of the device. I mean, it's quite bulky, heavy, impractical. I mean, it's great to have the positive effects from it, but I'm just wondering what the plans are there, and whether other people suffer with practicalities of humping it around, and particularly if you've got balance issues and other things.
Yeah, so just in terms of practicalities, we're going to talk this afternoon a bit more about practicalities. I'll point out that you will be using version 2 of the device, which is smaller and lighter than version 1. I don't know whether the company are working on making it smaller and lighter, although I suspect they are. And one of the nice things is that a lot of the weight comes from the battery, and battery technology is evolving quite quickly. So I hope that'll get better. There is another company working on basically an implantable intracranial version of tumor treating fields, which kind of looks really interesting and really attractive, allowing for obviously the huge problems about putting things inside your brain and all of those problems. So I mean that there is some technical development, but at the moment I think our focus is more on trying to get more people using it and more people using it better so they get as much benefit from it. Okay, right, we're going to stop there because we're a little bit over time. We're going to have a 10-minute coffee break. Very good. 10-minute coffee break. So we'll be back in 10 minutes and we'll see you there. If you've got questions, feel free to put them in the chat and we can answer them as we go along.